In the U.S., a rare disease is defined as one impacting fewer than 200,000 people, often not large enough to attract commercial treatments. In fact, today, 95% of rare diseases still have no FDA-approved treatments. Sadly, 30% of children with rare disease will not see their 5th birthday. Who is fighting for them?
When we work in rare diseases, it is an urgent mission. Our timeline then is not just a piece of paper and a goal. It's someone's life. You treat a patient with rare disease and you see this family who's been all their life thinking about the decline of their child. I like to think of them as a family treading water. We're people arriving the shore. I want us to blaze a trail and take on diseases others have been afraid to take on.
Working together, we can provide hope for these often neglected patients.
Next up, I would like to introduce our first speaker, Dr. Laura Tosi. She is an OIF Medical Advisory Council member, as well
in the U.S.
As well as a member of the OIF's Board of Directors. And please take it away, Dr. Tosi.
Hi, that's really, you've said everything I'm going to say. Well, I don't think we were planning on speaking per se, but we sure are here to participate.
Great. And I'd like to now bring on Dr. Jacqueline Bourgeois from the Hospital of Special Surgery. She is also a member of the OIF Medical Advisory Council, and she is going to give us a brief overview of areas of concern for mild OI.
Great. Thank you so much. A pleasure to be here again for those of you who are on in the morning, but it's great to see you in the afternoon or in the morning or the afternoon or evening, wherever you are. Melissa is just going to share with you my slides, I hope. They're coming up, I think. What I wanted to do is to just go over a few facts, I think, that we know or don't know about people that have a mild OI, and just so we're all talking about the same thing, and also just to raise some maybe talking points. So if you can go to the next slide, and this is for adults. We're talking about adults today. This is just my disclosures, just in case, to be fully there. Okay, next slide. So whenever I talk to people who have OI, who are adults, I always say, we need to talk about basically aging in general. And the key for aging in general is that generally, as we age, we know muscles are going to get weak and underused. There's going to be weight gain. I have just been thrown off. You probably, maybe you can still hear me, I hope. Somebody tell me yes.
Yes, you sound good.
Yes.
Good. Okay. Thank you. Okay. So go back to that slide. I'm sorry. My computer just went down. As you change the slides, my computer does something weird. So as you age for an adult, what are we thinking about? Your muscles get weak and underused. We gain weight. We lose hormones. We lose our hearing. Our tendons tend to rupture, males more than females.
Now we seem to have lost your voice, Dr. Bourgeois.
That's just aging in an adult. Now, if you look at the next slide and we go to aging in OI, just let's talk about some of the adult facts we know. That if you have OI, you decrease your fracture incidence after you go through adolescence. We know that. And we also know that we have two OI populations. We have people who are now becoming adults who've never seen bisphosphonates or any treatment as a talk about this. I might ask someone, have you, what's your age range, or have you ever been exposed to bisphosphonates or whatever? Because I think that's going to play a role in how we look at bone going forward. We clearly know that all OI patients are different. And that's really important because we have modifier genes. We just don't get the one OI gene. I think that's really important. And if we look next, OI patients are not exempt from normal aging. So if we go to the next slide and we say, okay, what happens in OI that's unique to OI as you age? Well, one, you revisit the fracture risk because normal aging leads to revisiting that fracture risk. But you start with that a little bit sooner. Two, you get decreased muscle mass, maybe because you haven't been as active, because you've been protecting your bones in different ways. With OI, we know that there's an increased risk of tendon ruptures, hearing loss, thinner cornea, and cardiopulmonary complications. So then if we look at the next thing, we know now we've got the OI risk, we've got the aging risks that go together. And on the next slide, we talk about general principles. So number one, remember, OI is not going to protect you from aging. So fight the aging the way you can. Be aware of it. Try to be proactive. Keep moving. And remember that OI is a collagen disorder. It's all systems where collagen is are going to be affected, not just your bones. So when you're younger, and I always pray that there are kids that are listening to this that are 16 or 17 or kids that are 10, so that we can be more proactive for the adults. And so I think that might be my last slide, just to get that out. So remember, again, tendon ruptures, flat feet, and oh, this is a question that came up, is that if you have a mild form of OI and you know you have type 1 OI, most surgeries, people always.
Uh-oh. Well, I think we have lost Dr. Raggio, but hopefully she will be back. In the meantime, I'd like to introduce our first panelist, Dr. Kevin Ricker. Dr. Ricker is a pediatric dentist from North Carolina, I believe. So Dr. Ricker, please take it away.
Well, hi, I am Kevin Ricker from North Carolina, and I have real mild OI, and I was very glad to be here. I was surprised you all asked me to come and be part of the crew, since I'm going to be doing the dental presentation in a minute, or in an hour, I guess. Not telling y'all to leave early to come to the dental presentation, but it's going to be dramatic. We were each kind of asked to pick a path point for kind of what would we want to talk about if we had, 5 minutes to talk to the mild OI panel. And for me, not surprisingly, the thing that kind of drives me forward is teeth. So as a kid, my OI was kind of much more bone centric in terms of how it affected my quality of life. I'm super on the mild end of things. I'd break about a bone a year, but it was all very straightforward. I'd break a bone, I'd go rest for, 2 months, and then I was done and I'd get back to my life. But once I became an adult and my teeth started to disintegrate, I realized how much more challenging that was for me to manage personally and financially and all of those things. And it really kind of turned around the way that I thought about disorder. And so I quit my job and I went back to dental school and became a dentist. And then I went ahead and specialized in the treatment of children. And I went to a program specifically where one of the guys who ran the place had a history in mineralized tissues. So I'm a proponent of taking care of teeth. Like the previous presenter said, it's so much more important to be proactive than reactive when it comes to teeth. All of the things that affect normal folks' teeth, and I use that in quotation marks because I've yet to meet someone normal, will affect your teeth. It'll just happen faster and rougher. So make sure you brush twice a day. Make sure you floss like you mean it. Try to drink pretty much just water and don't eat a bunch of sticky trash. And with that said, I'm glad to get on this crew here and be part of the open forum. And I look forward to hearing everybody else's stuff.
Thank you so much, Dr. Ricker. Next up, we have Robin Wright. She is a former OIF Board of Directors member, and she is based out of New York, or sometimes Denver, Colorado. She'll be speaking to you today about hearing loss. Robin.
Good afternoon, everybody. Greetings from Denver, and later today in New York, but I have been here for a couple of weeks, and I'm based out of New York. I have type 1 OI, a mild form, very mild form. If you saw me, you wouldn't think it whatsoever. Although I've broken about 35 bones, the ones that you count, I have to say that my hearing loss has affected me much more greatly than my bone problems. As most of us were very prevalent to breakage when we were younger. Once that I started getting older and out of puberty, I started breaking a lot less, but that's when my hearing loss started as well. I was about 8 when my mother started noticing that things were, I wasn't very clear. And at that time, they monitored me. And then at age 13, we decided to do a stapendectomy. This was in the 70s. This is when you still had to shave your head to have an ear surgery. It's much more easy now these days, as I understand it. It's an outpatient procedure, and you don't have to, and you can wash your hair. I couldn't wash my hair for 6 weeks. That was not a pretty look. But it's much better these days, as I understand it. And my stapendectomies held me for many, many years. I didn't have to actually get a hearing aid until I was about 16. And then I got a second stapendectomy when I was 18. And that really improved my hearing until I was in my mid-30s. And even that started not being as good. My hearing started fading again. So I turned to hearing aids, which have been wonderful. The type of loss that most of us have is a conductive loss, most usually. I can hear perfectly well. I can hear speech, I can hear noises, as long as it's loud enough. So mainly the type of hearing loss that we have is a conductive loss. The bones don't move well enough to carry the sound waves into the inner ear, where the nerves can pick it up and tell your brain that you're hearing something. So our type of conductive loss, most of us, some of us will have some nerve damage, but mostly we'll have conductive loss, which can be fixed most of the time with amplification. It's a little bit different than having age-related hearing loss, because age-related has some nerve damage, but generally conductive loss, and my hearing is perfectly fine if it's loud enough. My speech patterns, my speech patterns are formed. I can hear everyone and everything if it's loud enough. So there's also some other ways. I've mentioned the stapendectomy. I've mentioned the hearing aids. There's also the possibility of some cochlear implants. I know a few OI folks who have had cochlear implants. I have not explored that because my hearing aids made me very happy, and I deal with them extremely well, and would advise anyone to explore that, because it is one of the least invasive, expensive sometimes, but least invasive, most life-changing appliances that you will ever have. They're easy to obtain. We have been, the OI Foundation has been working very hard to get some hearing aid aid on to insurance policies, and we're making some headway, and everyone's still working on it very hard. And that's something that's my hot button issue because it's affected my life so much. But I do have to say that the new hearing aids are fabulous. Please don't have a stigma. Please don't think that they're just for old ladies and old men, because they aren't. I had my first ones at 16, and it really enhanced my life. I really didn't have any idea how much I was missing. And then again, in my 30s, my hearing got much worse, and I really, truly didn't have any idea how much of the world I was missing. So please don't hesitate to get your hearing tested. It's half of mild OI type 1 have hearing loss. Don't be afraid of it. Don't be ashamed of it. You'd get a pair of glasses and you'd wear them happily if they allowed you to see. And why wouldn't you want to hear the things that are meaningful? One thing that I might want to mention as well, that we are in the OI Foundation and the Hospital for Special Surgery are beginning a protocol at not experimental treatment, but a provisional treatment for hearing loss out of the Hospital for Special Surgery in New York. So if any of you guys come to New York frequently, or you live in the New York area, Holly LaTurco and Kathleen Raggio are very involved in this hearing study, which we're trying to determine if risedronate, which is a type of bisphosphonate, the name that you're probably familiar with is Actimel, actually will help not only your bones, but your hearing tinnitus, which is even as bad as the hearing loss, and hopefully some dizziness. So it's a experimental protocol that we've just begun. We'd love to have some more participants. We need to study this because, like I say, half of us have hearing loss, and it's so easy to take care of. If you guys have any questions, you're ever in New York, I'd love to meet with you, or in Denver as well, or anywhere in Colorado, or in Arkansas, where I grew up. I'm happy to help and answer questions at any time. If you have questions about the hearing study, I can help you. Holly LaTurco can help you. The OIF Foundation can help you. Kathleen Raggio can help you. We're all here to support each other and make us the best citizens that we can be. It's very nice to meet you all. I hope that you'll put up some hands and ask some questions, and happy to talk. Thank you.
Thank you so much, Robin. Moving along, we have another former OIF Board of Directors member. Carolyn Tipton is an adult living with mild OI in Los Angeles, California. Carolyn.
Hi, welcome to everybody. Glad to see so many faces here that I know and love. And today I want to talk to you a little bit about my pregnancy experience and what I learned that I wish I had known then. And so this will be of interest to those of you who might be interested in pregnancy, but also really what I learned applies to all of us, male, female. And since my pregnancy, one thing I love about our medical community is they really listen to us. And so when we're at national conferences, Dr. Raggio and Dr. Krakow heard several women talking about their pregnancy experiences, and we all had the same kind of issues. And so they really pushed for a pregnancy study, which was completed recently and published, and it really confirmed sort of my experience. So now there's some really great information out there. But basically, I want to encourage all of you who might be interested in pregnancy to go for it. We really don't have any additional problems as women with OI. It'll bring you great joy. I love being pregnant. I delivered naturally, no C-section, had a healthy baby, had no problem breastfeeding. My problems really came postpartum, and these are things that we all need to be aware of. I had really painful compression fractures of my vertebrae. And if you all have had compression fractures, you know what I'm talking about. They're really, really painful. I also sort of went into full-blown osteoporosis in my early 30s after pregnancy. And so here are a couple of things that I wish I had known then. The first one is how important it is to find an OB and a pediatrician who are familiar with OI. And for most of us, that's almost impossible. And if that's the case, then to find a doctor who's willing to learn. And for us, that means really being our own advocate, learning as much as we can and helping to funnel that information to our doctors. Now, the OI Foundation has this phenomenal fact sheet available on the website. So if you haven't seen those, go check them out on the website under, I think it's the Information Center and then fact sheets. And I print the ones that are relevant to me, put them in a big old notebook, and I take them with me to any of my doctors. But that's been super helpful. Also, we want to let our doctors know a couple things. One, with OI, we have fragile skin. So you may end up with a few more stitches at birth. So if your doctor's prepared for that, there's no surprise. The study also found, and this is super important, that we may be at a higher risk for blood loss. And so this is really important, and we're going to talk more about that in just a second, but important to let your doctors know. And then the third thing is just this void of continuing care postpartum for women. So I wish that I had been aware that, you know, when you're pregnant, your OB takes care of you, and when you have the baby, the pediatrician takes care of the baby, and then you as the mom kind of are not seen anymore. And it's so important, and this was my mistake, to stay, you know, to have good nutrition, to make sure that for bone health, you're really taking your vitamins and supplements for to build your bones. And this is also really important. If you choose to breastfeed, it's great if you want to, all good if you don't. But if you choose to breastfeed, know that there is a point at which the benefit to the baby drops and the risk to your bone loss increases. So I love breastfeeding. I breastfed way too long, 18 months, and it really was a detriment to my bone health. And I went right into full-blown osteoporosis. So just talk to your doctor about that. What length of time? I think the Academy of Pediatrics recommends 12 months, but talk to your doctor and really adhere to that to protect your bones. And then the third thing is, I wish I had been more diligent about core strength. And this is true for all of us, not just in pregnancy. I think this led to my vertebral fractures. Having good core strength going into pregnancy, maintaining that core strength after you have the baby, working on proper posture as you lift. You know, those babes are teeny tiny when they come out, but they gain weight really fast. And those carriers are heavy, and we torque our bodies to get them in the car and over the crib. And so I think if we really are careful about the support and stability of our spine, we can prevent those postpartum vertebral fractures. And so lastly, I'd just like to say, you know, I think it's really important that you advocate for yourself. My doctors have learned, they say to me, you know your body better than anyone. And so just advocate for yourself, seek that knowledge. The website at the OIF is really valuable. If you want more information on this or menopause, be sure and go to attend the Women's Forum, which is a little bit later this afternoon. And then lastly, I want to talk about what this pregnancy study found. And I think maybe Dr. Raggio was going to talk about that when we lost her, about our higher possibility of blood loss with OI. And so you want to be aware of that also if you just have surgery. Make sure your doctor knows this. And I did not experience that with my pregnancy, but I want to toss to Christine Rossi, who can talk a little bit more about that.
Thanks, Carolyn. Hello, everyone. Great to see you all. I am Christine Rossi, and I am excited to have, I kind of say ditto to that, and ditto to that, everyone that has spoken before me. My focus today is going to be talking a little bit about cardiopulmonary, but as Carolyn said, I'm going to spend a few minutes talking about kind of my experience. I have type 1 OI, as you know, as we all do, on the panel, and so talk a little bit about my experience leading up to it. I also had a very kind of, as Robin said, very similar, kind of the 35 to 40 breaks growing up. Pretty, you know, didn't take a lot to make it happen. And then as I moved into adulthood, I got very focused around kind of, okay, what now? Because I feel really good. And everyone's, you know, kind of, we grew up in a space of, once you stop breaking, you know, go do your thing and live your life. And so I was very interested around, you know, how that would affect my systems and my overall body and structure as I got older. And there was still so little known around that. When I made the decision to have children, I was very focused on how will I deliver. I did my homework. I came to my conferences. I talked to Dr. Krakow and said, you know, which way do I go? Do I go, you know, vaginal? Do I go C-section? And ultimately, the determining factor at that point, I think there's been varying, you know, recommendations depending on every case for me, because I also learned that my child would have OI as well. So kind of 2 OIs equaled a C-section. For me, my first one was more blood loss than normal, but not catastrophic. And interestingly enough, my second one was borderline catastrophic. So having a major uterine hemorrhage. And ultimately, I was in great care. I'm out of Boston, and I had the head of our, you know, maternal fetal medicine at Brigham and Women. Couldn't have been in better hands. And ultimately, she said, it's your OI. It's the tissue. It's not that you bleed more. It's that your tissue is more fragile, which lo and behold makes a lot of sense, right? From a collagen perspective, makes a lot of sense. So for me, you know, that was obviously for a couple of reasons. One, determining kind of future childbearing caring, and also teaching me something that I hadn't had exposure to prior. I hadn't had major surgeries. I hadn't had bleeding issues. So this sort of opened up an avenue for me around tissue fragility, which again, as Carolyn mentioned, started to, make me think about other surgeries. If I were going to have a surgery, my tissue, and I think there's different variations within different types and with different people's experiences. Even within my own family, it varies when we've had surgeries. But for me, it is something we have to vet for and make sure I've covered all of the bases. I had to have part of my colon removed a few years ago. And as Dr. Raggio knows, I was saying, am I going to be okay? Am I going to be okay? I have to do this, which again, thank God for our medical experts, because who knows where I would be. I mean, that was a really defining moment for me when Dr. Raggio assured me, that we can get there, we could get there. So I think it's just an important data point as you think about it, not kind of to be a deciding factor or not, but more just a data point around awareness, because understanding that your tissue may have some fragility to it opens a conversation with a doctor around, is this an essential surgery? Is this something I want to do? Are there other ways to get there? Should I be concerned about it? I had an Achilles rupture and it wasn't a full rupture. And at the time, the doctor made the recommendation not to do the surgery because it wasn't a full rupture. And given the tissue fragility, he was a specialist in his area. So it just puts us in a little bit of a different place in terms of vetting out all of the options and making sure we're doing the right thing for our own case and situation. So with that, I want to get into a little bit of the cardiopulmonary kind of component of what I'd like to share. So initially, I come from a family of multiple generations of OI. And so my grandfather actually passed away at 52 from an aortic aneurysm. And so at the time, as I grew up, there was no real connection to OI. In fact, they said, no, it has nothing to do with OI. My father was monitored because his father died so young from such a specific heart kind of cardiac situation. So they monitored him. Again, no connection, kind of this just can happen, but it's in your family. But no one was really making a connection to the OI. And then at a certain point, he had to have a valve replacement. So a lot went into that process, obviously, having OI and understanding the impact that it could have. So it's important. It's something for me that has always been important, because I've also watched, and a lot of us have in this room, a lot of our friends bump into issues around cardiopulmonary challenges and ultimately lose their lives because of it. And so for me, it's kind of hard to not acknowledge the fact that there's an OI component. And so much so, a number of years ago, we made a commitment to focus on that. And obviously, Tracy Mulroy and a whole host of others started the Jamie Kendall Fund in order to basically get to the bottom of it. And then we in Boston jumped on board a few years ago. But ultimately, I think the key takeaways there are, and Dr. Raggio, I know will speak to this, but there's still so much more to learn and to understand and to know and to define. I know for me, because it's in our family, I get echocardiograms every 2 years. I started getting them when I was 30 because I know it's going to be a potential challenge. And honestly, I've watched friends who have mild OI, a number of them have either themselves or members of their family have the same exact incident happen and die prematurely because there was no recommendation and no awareness around, if you're not having any issues, why would somebody who's 35 get an echocardiogram? Just because you have mild OI? Probably not. And I'm here to say, I think that everyone who should have some sort of awareness around that, even if you get a baseline. That for me was what I did. I got a baseline. I knew it's something I need to be considerate of and aware of, and getting on board with our Boston Gala to support the Jamie Kendall Fund from a cardiac perspective and work with Dr. Raggio to make sure we get to the bottom of it and really get the answers so that we have greater recommendations. But I would recommend every single person who has mild OI go get an echocardiogram, and that may be extreme. But I feel like, again, having heard so many people around me that never had any sort of challenges, didn't even have any OI challenges, were very healthy, very fit, not high risk for any sort of cardiac issues than have an aortic aneurysm and pass away, to me just doesn't make sense. So I encourage everyone to do that as well. I'm happy to be available on any of those fronts and probably any other OI related front you need. Feel free to reach out to me. And with that, I am going to turn it over to Melissa.
Thank you so much, Christine. That's very, very important topics. Next up, we have Jeffrey Esslinger, all the way from Honolulu, Hawaii, to talk about his experience and his concern about pain management.
Hey, good morning. Aloha, everybody. Pain management is a very personal, to me, obviously, but I think everybody has their own journey as it relates to pain management. But also collectively, we also have our frustrations and challenges with pain management. So, I'm just going to talk from my perspective and I guess the evolution of pain for me. And it's interesting, as I was thinking about this, is that when I would break as a child, it's not the pain things that I remember. I do remember two particular situations where I remember the pain. The pain kind of goes away, but you remember the actual break. But it's interesting, as I have gotten older, and if I have broken, they've been much more significant fractures. And so with a lot of pain associated with them. And I dealt with the pain in a situational, in an active fracture situation, but that healed over time. But as I've gotten older, now I just turned 53 a couple of weeks ago, I feel that it's all coming back to haunt me because I am in a constant, like, low level state of pain, and really being in Hawaii, I was very fortunate to have lived in the Washington, D.C. area as well as New York area for many years. But coming to Hawaii, there are very few, if any, physicians who have any knowledge about OI and about pain management. And we were on a session earlier today, and it's really hard to find solutions because, as other people have mentioned throughout the conference, is that we are shopping for medicine. So I have not been on anything stronger than an extra strength Tylenol, probably for the last 2.5 years. I definitely have needed more, but have not had the opportunity to take anything stronger. And I think it's through, our continued resilience and other things, we just kind of suck it up and move on. But I've noticed that when Dr. Jane was talking yesterday, he mentioned about pain interference. And I never really had thought it that way, but I think that our everyday and our high threshold of pain, it's really something that's interwoven throughout our life, whether we're in an active injury situation or not, and how much that takes out of you physically, emotionally, stamina, all of the above. And I think that those are things that we always need to keep in mind. Tony mentioned his fitness journey started when he was in his 40s. My fitness journey started when I was in my 20s, but I probably stopped in my 40s. So I think that I need to reevaluate that and revisit that. But I think as we age, we have to look for other solutions and continue to reach out to other professionals if they're not able to assist you. My general practitioner, who's a great diagnostician here in Honolulu, she is trying to send me to a physiatrist. The problem is the physiatrist won't see me because they think that I am shopping for pills. So she's sending a referral with a very detailed reason why she is sending me to that specific doctor. And I think as you're more active throughout from your adult life, and if you are a professional, if you have a professional life, or even if you're non-professional, but you have active things, and you kind of learn how to cope with that background pain. But as you take that time to stop and you realize that your stamina, you need more recharging time between events, even throughout the day, that is when things are starting to change. And so, I'm kind of talking in circles a little bit, but I just think that really have the conversation with your physicians. And what I need to tell myself, and what I was very fortunate about living in Washington, there were a lot of wonderful professionals, some in those that are on the call, but use the OI Foundation as your base. So if you move to a new area, or even if you're in your current area, look through that list of physicians that are on that list. And many of them may be pediatric specialists, and you may be 50, but please reach out to them, because at least they have a perspective, and either they may make exceptions, their institution may make exceptions to see you, or they would be the best place to make recommendations to other colleagues in the community. So it's really all about the information. It's through these forums. And that's really all the things that I was going to say today. So happy to answer questions when we open up the Q&A.
Thank you so much, Jeffrey. Our final panelist today is Jacqueline Bourgeois. She is an adult living with OI, actually in the Washington, D.C. area. Jacqueline?
Can you hear me?
Yeah.
Okay. Hello. I live in Washington, D.C. a long time ago. I used to be on the board, like a really long time ago, with the wonderful Jamie Kendall and Tracy, who I see is on here, and Christine. And I wanted to talk about sort of, now that I'm getting older, I'm in my mid 40s, that it's becoming quite apparent, sort of, it goes along the lines of all the great panelists, of how you have to really be a self-advocate and really push for your own care. For example, I had a great endocrinologist named Dr. Shapiro, who many people here may know, and he really is no longer available. So I have had to go to so many different doctors to try to find somebody with any sort of connection to OI. I have a great primary care who said, you should go to the head of Georgetown. And the head of Georgetown lady basically told me I just needed to take liquid collagen and that all my problems would be solved. I mean, so these type of thoughts are still being given out there. So you run into this problem, you go see somebody else. You tell them, thank you for your time. You're wrong. And I'm going to go. And it doesn't just stop there with an endocrinologist. It could be your primary care. It could be an ortho. It could be cardiopulmonary. I have all the different things that have been discussed on this panel. I have aortic insufficiency. I have hearing loss. I am still breaking, and my breaks are actually have been increasing since I had children. My bone density went way down. And along the lines, I've had to really educate and push, just like you would maybe if you did for your own child. I have to treat myself as my own child and push and say, no, this isn't going to work. No, I'm not finished with my questions. No, this isn't going to work for me. My father, who has OI 76, is in total renal failure, and he is on dialysis 3 times a week. And I bring this up because this is something I rarely hear discussed about with people with OI. The reason is because he's been on decades of all sorts of medications. And when they put it all together, for his heart problems, for pain management, for high cholesterol, high blood pressure, some NSAID, one of those type of drugs, they're like, well, you really should be taking all this stuff, because he had never really advocated for himself. My mother finally sat down and said, what are these things that we can get rid of? And it's almost too late. His quality of life is very poor, and he's still alive, but he has to go to dialysis 3-4 times a week. He can't, or he'll die. I don't want that for you. I don't want that for me. I want to make sure that everybody does not get intimidated by medical professionals. You are the expert of your body, and you are the one who knows what it's like to be you and the pain and the experience. And I'm not a very pushy person, but I will be at the doctor. And I think you could go on the OIF website or the Facebook page and maybe ask for, how should I approach a doctor this way? I've seen good discussions like that. I went to the doctor and they told me my kids got OI and they'll outgrow it by the time they're 15. So what should I do until then? That kind of stuff. Like hocus pocus is what I call it. And it's not doing any of us any good. Because, I heard this great tagline at another, about 10 years ago at one of these conferences: we're too sick to be well, but we look too well to be sick. And we're not taken seriously. So if there's anything you can take from it, it's just really, really don't if you think the doctor's wrong or you think you still need something else, keep going. Don't stop. Don't end up like my dad. I don't want to end up like my dad. Be very vigilant about going to your doctor, doing your screenings, eating well. Please eat well. Please don't smoke. Please really limit how much alcohol you have. And please, please, please exercise if you can. I think Tony's on here. He's a great reference, Tony Jacobson, for those type of things. So, I'm using my father as the cautionary tale. So take my tale and be like, I remember that lady that wouldn't stop talking in the forum about her dad, and I don't want that to happen to me. And use that to take care of you. Because unfortunately, there's still doctors that are like, you take this liquid collagen, it'll help you, and it'll all go away. It's all you need. I was like, oh my God, lady. So there you go. There's your funny story. It's true.
Thank you so much, Jacqueline. So now we are going to open up our question and answer period. Just a couple little housekeeping notes. We're going to use the chat for the Q&A. So if you have other physician recommendations or people that you have seen that you've enjoyed, we love to get those recommendations from you all, but please send them to our health educator, Jessica Ransom. We'll put her email address in the chat. That way we can capture them. And then also, I know that everyone here loves to connect with each other. And I think, doesn't always have the opportunity to meet new members of the OI community, especially those of you with mild type OI. So I would highly suggest using the chat function in the private message version, and you can exchange information if you'd like. That might be the cleanest way to do that. So moving to the questions, I'm actually going to start with a question for Dr. Ricker, since I know that you have to scoot out of here quickly to get to that dental panel. Have there been any successful dental rehabilitation for OI patients? And that might actually be a bigger question that we suggest you go to the dental panel or watch the recording of the dental panel after this.
Sure. Just in general, the trick with OI is that it is, and as every other panelist has talked about, OI for one person is totally different than OI for the next person is totally different for OI for the next person, even within the incredibly broad spectrum mild OI. And so you're going to see folks that have had dental implants successfully. You're going to see folks that have had dental implants fail. You're going to have seen people that have been restored with crowns and bridges and fillings. And then you're going to have seen people that were in dentures by the time they were 18. And so it's very difficult in kind of generally speaking. Can you fix a mouth with OI? Yes, sometimes. Which is, of course, what virtually every one of us gets to every single medical, dental, anything question that we ever ask any qualified professional is that, yeah, sometimes it works. And I wish I could give you more help in that, but it really is case by case situation on both your specific quantity of bone in a given site and your quality of bone in a given site. And then what other things do you have in your mouth that are working that you can use to support whatever fix your clever dentist comes up with?
Thank you so much. I see that Dr. Raggio has rejoined us, and I know, Dr. Raggio, you got cut off. And I know that you've spoken about this in the past, but how would you define mild OI? Mild OI. Is it simply type 1? Is it a certain number of fractures? Is it, what is your definition process?
So when I'm talking about mild OI, I mean, the person who generally has what I call a haploinsufficiency, which is how we define type 1. So for all of you you all know you have type 1 collagen in your body. So that's what's in your body. That's what's in your bones. It's in your ears. It's in your heart. It's in your lungs. And if you have less type 1, that's what we call a haploinsufficiency. So you're making less of that. And that's the definition of someone with a type 1 OI, which we tend to say is mild, meaning that you don't have a genetic change within the collagen itself, which would give you what we call the more moderate or severe forms. So that's how I try to define it. So I was taking notes during this. I think it's really important that people understand, have they had genetic testing? And do they actually know what they have? Because that's going to inform your doctor. If you have a haploinsufficiency, meaning you're making less, but you're making normal collagen, that says one thing. But if you have collagen that is being made abnormally, and that's generally what we think of the type 3s or 4, then that's going to be different. So we don't want to, when I talk about it, I'm talking about the people who we have tested and we know they have less of normal type 1 collagen in their body. And those are people who years ago, as you've heard stories, people thought it's not so bad. Hence it got the term mild. But as you hear, it affects your heart, your teeth, your lungs, everything. And so that's really important. So I think that's how we define it. And if I could just say one other thing while I'm so afraid I'm going to get cut off on my own phone here. But I saw some of the questions coming in. And I think the other thing you need to know is you need to know you have this one gene or this set of genes that have had you have type 1 OI, you have a mild form of OI, but you inherit all other genes from your family. And so that is going to play, we call those modifier genes. So if you happen to have a family that's had genes that have weaker bones or weaker hearts or weaker whatever, you're going to have the whammy, a twofold effect. And I think that's so important. I tell people you have to know your family and you have to look at it. And that's why we give these generalizations of what to ask. Not that we have the answers, but you have the right questions to ask your doctors and the right information. So I think that's important. And again, we're talking about this because aging doesn't care whether you have OI or not. You're going to age. And when you hit 45 or 50, your body's going to hurt more. Your muscles are going to be weaker. You're going to start to lose your hearing. You're going to feel crappy. Hello, I've been there. So, this is what happens. And you have to realize that you're at a lower threshold because of that quote unquote mild OI that you were able to go along maybe A-okay until you hit your aging again. So I just wanted to get that background out because I didn't get to go into a lot of that because I got thrown off by me. So.
Melissa, Laura
Yes.
Tosi, can I make a quick comment? As a clinician, I think the biggest change in my personal thinking and in my care has actually been some work by Dr. Solens. And he's actually argued that we should call OI mild, moderate, severe, and very severe. And what's important for me is that I had always assumed that, oh, well, if you have type 1, I don't really have to worry much about spinal compression fractures. And in fact, I have a bunch of kiddos who the only fractures that they've had are vertebral compression fractures. And catching them early turned out to be really important because with treatment, they've been able to reconstitute their vertebra, which means that they have a much, better trunk height. I think they'll breathe better. Everything will be better. And this, of course, goes to me always saying we need to learn more. We need to learn more. But just a thought. There's more to type 1 than we thought.
Thank you, Dr. Tosi. Actually, I'll stick with you, and then Dr. Roger, you can jump in on this too. We have a lot of questions about bisphosphonates. What are the current indications for starting treatment? Is there a preference for PAM versus ZOL? How do you determine when a person with mild OI would need to start it? Do they need it? And which is there a preference of which drug?
Oh, that's a toughie. And I think the first thing to say is it depends on where you live. And I don't mean that in a negative way. We're still all feeling our way. As someone who deals with a lot of children, I feel much safer starting out with pamidronate. Those kiddos will have a much lower incidence of those flu-like symptoms and whatnot that come after starting pamidronate or ZOL. Once the kids are at school age, boy, do we get them into ZOL, because mom doesn't want to sit around and waiting for that 4-hour infusion. I think the much tougher question is, when should a child with OI be treated? And as I was just saying a minute ago, vertebral compression fracture, I'm all over you like a rug. It's everybody else that I don't feel that I know the right answer for yet. Long bone fracture, multiple long bone fractures, I'm going to treat you. But if we just found you by mistake, then maybe not. Kathy, what are you doing?
So as far as if we're looking at people with mild OI, so if we're looking at the children, I probably do. So first of all, I think everyone, whether child or adult, and I know Dr. Tosi does this, but you need to have a full metabolic workup before anybody starts you on anything. So you need to know, are you a high turnover or a low turnover person? And you look at your bone markers. And when you do that, you're then able to say, if you're a high turnover person, we want to shut down that turnover. And that's what bisphosphonates do. And that's why they work in children, because children are growing. You're not making better quality bone. You're just stabilizing what they have a little bit better and decreasing the fractures. When you look at, so the short answer in children is I look at how many fractures they've had, what are their bone markers, and if they are a high turnover person and they have a mild OI, I'll consider putting them on either pamidronate or zolendronate. Either one, it's irrelevant. That's a timing issue. Though zolendronate is a lot more potent and you can't back off it as quickly as pamidronate. For adults, you then have to do the same thing. You have to say, why would I treat you? You're not just going to treat a DEXA scan. Oh, my DEXA scan is going down. You have to look and say, well, why is it going down? And if you guys were here in person with me, I would make you all raise your hand and tell me how many people know their vitamin D level. Because I would tell you that most people don't have adequate vitamin D and calcium for being a human. You need the same amount whether you have OI or you don't have OI. And so go for the low-hanging fruit, folks. Get your vitamin D checked. Make sure it's up in the 50s and 60s. That's where it should be for your heart, for your bones. Then, if you're still fracturing or losing bone, and you've corrected everything, you then need to look high turnover, low turnover. Most people with OI as they age are low turnover, meaning their osteoblasts are not performing as well, the ones that build your bone. And so what has come in the literature? What do we know? I've done 30 years of research in the lab with animals that have OI, and so some of this comes from that. But what do we know? We know with people that have had a mild OI, known to have type 1 OI, we're going to use that definition, that some of the bone stimulators have been effective. Things like PTH, parathyroid hormone. You build your bone, but then you have to lock it in with some bisphosphonate. We know that bisphosphonates by themselves are not necessarily so great for adults. And so in adults, we don't have the answer. We have at least something to offer people that have mild OI, but people that have that actual mutation, and that's why I tell people it's important to know, we know that those drugs like PTH do not seem to help. And there are other drugs that are coming down the pike, the anti-sclerostin drugs that you might have heard about, that and other drugs in different lines. So my answer is I treat everybody as an individual. You've got to get certain basics. You've got to get a full metabolic workup. You've got to know are you a high or low turnover. You have to have your vitamin D and calcium, your vitamin D at the correct level. And from there, you then weigh risk benefits. Why are you treating? Are we treating the DEXA scan, or are we treating you've had multiple compression fractures? And that's how we take it from there. So that's my long answer. I'm sorry, but I want to make sure it got out as a package.
Thank you so much. I'm going to go ahead and ask a question for all of our panelists now, and we'll have you each take a turn answering if you'd like. Oh, Dr. Ricker's heading out. See you later. After this session, everyone can move over to the dental, or we will be recording the dental, and we'll share that later online. So how do you each cope with anxiety? That fear of, will I break something if I try a new activity, or if I'm especially active? I see Jeffrey nodding, so I'm going to start with him.
Oh, okay. I think, so one of my fears was ice, so I don't have to deal with that anymore. But it's still water. Like, I am so hyper aware of anything that is wet or potentially slippery. If I see a marble floor, I honestly have to stop and to get my bearings and think about it. I mean, it's either a PTSD or some sort of something, but I literally stop when I see these types of things. And I think that it's all those types of things that you can be mindful of. And I think that for me, I premeditate everything in my life. When I was driving, I would think about my route. I think about where I have to go. I try to take my time, because I think all of those things combined keep you safe, or give you that feeling of safety. But I think it's different for everybody, but that's kind of what I do.
Thanks, Jeffrey. Jacqueline?
Oh, sorry. I do have a lot of anxiety that increased after I had children. And I have had some very severe breaks that have required surgery, from little to no impact since having children. One involved chasing my child who had run into the street. So I actually went to therapy for it, and talk therapy and cognitive behavioral therapy. And it took me a very, very long time to find a therapist that I could connect with. And there's a real shortage, a huge dearth of mental health professionals. I actually had Dr. Shapiro at the time, and my PCP, who's a wonderful woman, Dr. Burke at Georgetown, get me into a special program that deals with health and anxiety. So I don't know if those might be easier. Having OI qualified for that. They dealt with a lot of cancer patients and those type of health anxieties. But And I do take medication on an as needed basis, but there's nothing wrong with taking something daily. I just need, I take Xanax if something's really bad. I have a lot of anxiety regarding traveling, going to the airport, because I've broken doing stuff like picking up luggage or trying to catch my plane. Someone dropped a computer on me once. It came from the overhead carriage. I mean, things that are really outside of your control, but I don't want to let it stop me from living my life. And when you have kids, you're like crying on the inside, but don't want to cry on the outside, because then your kids will, they'll pick up on that and like everything goes to, what. So I would talk to someone, and it can be very frustrating and very hard to find someone who's taking new patients or taking your insurance. Or I would then reach out if you have like I did, I reached out primary care and I said, can you call them for me and say, can you fit her in? And that's how it helped me. I've tried meditation. That didn't really work for me, but that works for a lot of people. And there are a million apps for stuff like that. But just like other advocating for other parts of your health, you shouldn't, if you're anxious and it's really interfering with your daily life, don't ignore it. You can find me on Facebook and email me, and we'll try to find something. I mean, this last year's been a doozy. I would expect your anxiety to go up. There you go.
Thank you. Robin, I saw you unmuted yourself. Would you like something to add?
I don't have a huge amount of anxiety about my OI on a daily basis, but I have had to make myself slow down. I'm a big person that's always moving and always doing something, and I can't move as fast as I did before and not pay attention to my steps. My feet have to be planted. I have a great fear of falling. I have a real fear of falling down an escalator. I don't know where that came from. I've never fallen down one, but I am just more careful and more slow and more plotting about where I'm going, what shoes I have on, and things such as that. Just really being careful. And if I do feel a little bit tense about it, walking or uneven ground or something, then I find that engaging my core helps me stay straight and helps me stay strong. I tend to lean forward when I walk, and that's one of the worst things you can do because you'll flip every time. And learn how to fall. There's a special way to fall. You don't want to fall forward and break your wrists. So learn how to fall. Practice on your bed. Don't practice on the street, but it does help.
Thank you. Christine, did you have something you'd like to add?
I do. I think we can all relate to this. That's kind of, the anxiety around stairs and ice and water. I'm kind of nodding my head. Yes, 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 and yes. But I will share something. When I went through the process of, when I had spontaneously ruptured my Achilles and I went through pretty significant physical therapy, I actually came across a physical therapist who also specialized in what's called craniosacral therapy. And it's kind of a specific, within the physical therapy field, it's kind of a specific sort of therapy that kind of addresses alignment and addresses your kind of cranial sacrum connection. But it also, for me, the woman, and I still see her, she spent a lot of time releasing the trauma of my fractures, which is for me what causes the anxiety. It's the memory and the PTSD around the falls and what they mean for me. So to be honest, that was really a game changer for me. I started it a number of years ago, and I always had anxiety, and I continue to have anxiety, but for me, that's very helpful. So if anyone's in a situation where they can, it's CST for short, but if you're ever, are in a situation where you need physical therapy, I mean, even when I don't need physical therapy, I see her still. She helps there. And I want to make it really clear, there's no pressure. It's not like chiropractic work. It's literally like she barely puts her hands on and kind of moves through. And it's a little bit of like physical therapy and emotional therapy in one. But what I found is the release of, because I think for some of us, I know for me, I have certain bones that however I fall, no matter how I do it, and Robin, I'm a terrible faller no matter how hard I try, I'll always break kind of the same few bones. And so through the process of going through that, it's been really, really shockingly helpful around my overall anxiety. So wanted to share.
Thank you. And Carolyn, do you have experience with this?
I think we all do, right? But for me, it's more recent as I've been aging that the anxiety has gotten, to be more of a problem. When I was younger, the way my parents parented, and this worked well for me, was if I broke, fell off the bike and broke a leg, as soon as the cast came off, they put me back on the bike. So I wasn't, I didn't, have PTSD issues about that. And that seemed to work for me. And like many of you in my 20s, I was kind of fracture free and living life and feeling good. And now as I'm aging and postmenopausal, I'm starting to have more fractures and I'm getting more nervous. Like all of you have said, here in California, we don't really have the ice issue as much, or water, but just about falling. And for me, I'm really working on my balance is not great. And so physical therapy has been really helpful. Pilates has been really helpful. And I found if my doctor gives me a prescription for physical therapy, insurance will typically pay for it. And then the physical therapist can use Pilates on me. But when my doctor wrote a script for Pilates, insurance kicked it back out. So that was helpful knowledge. And the Pilates, which is also really helping my core and my balance, has helped. And then what also helps my anxiety a little bit is just being prepared. And I don't know if you all attended, we had a regional conference in LA and Atticus Schaefer spoke, and he's the kid who was on the middle. And he talked about how he was a prepper, someone who prepares for the, apocalypse. But here in California, we have to always be prepared for earthquakes, and wherever you live, you might have to be prepared for some other natural disaster. So I just try to be prepared. And I have my, doctor's phone numbers, cell phone numbers. And if I travel, it might be a little obsessive, but I check the OI site and I make sure I know what doctors and hospitals are near to where I'm traveling. Should I need something? That helps me a little. And then also I'm a big fan of mindfulness. And I don't know if the OIF did a session with former board chair Sharon Trahan on, it was like a guided imagery mindfulness session. And I thought that was super helpful. And so there are lots of, mindfulness is sort of a big area, and you kind of have to find what works for you, and not everything will work for you. And there are some good apps, and you just have to explore that a little bit individually, I think. But those are things that have helped me. And yes, anxiety is a big issue.
Thank you. So moving back to our physicians, Drs. Raggio and Tosi, we heard Christine mention earlier about getting a regular echocardiogram. Would you suggest regular DEXA scans? And if so, how often for our mild population?
I think that's a great question. I don't think there are any standards. I hope all the ladies are on the women's get together. I think that you want to know where your DEXA is when you're young. I totally support Dr. Krakow that unless you have a compelling reason not to be on hormone replacement therapy at menopause, you need to go on it. Because right now, for the perimenopausal woman, that's the best treatment we have for your bone. We don't want you on bisphosphonate for forever and ever. And we're not really sure about the other drugs. But HRT, hormone replacement therapy, is very protective for you. I do think it means that then you do have to be far more careful about your cardiac follow-up and your breast cancer follow-up, because there's no question it increases the risks. But the disability from a fracture is going to be far greater. We follow our kiddos once a year up until they turn about 18, 19, and we know we've gotten them to be the best we can get them to be. And then we back off and get DEXAs every 2 or 3 years. But I think it's unknown in adulthood. But I think you have to ignore your insurance if it won't pay and get one at least every 3 to 5 years. Kathy, I'd be interested in your thoughts on this.
Yep. Laura, I think we are on the same wavelength, you know, and that normally in the adult population, we try for every 2 years to get them. And then, you know, clearly at life-changing events, you want to have, so you want to know when you're finished growing what your bones look like. So that might be at age 18. And then you want to know, again, if pre-birth of a baby where you're at, and then you would want to know after. And then clearly and I want to really then say probably we do it every 2 years, we aim for it. And, you know, I think you have to do it every 5 years. I mean, going more than 5 years, I don't think is right. I think the answer falls somewhere at 2 to 3 years. The one thing about speaking onto what Dr. Tosi just said about hormone replacement, it's really important, and I stress this when I talk to the adults, as I know Dr. Tosi just did, is that you have to start in a woman. You've got to start when you're in the perimenopausal stage. You can't finish your menopause and then start, because those were the women who had increased heart issues, and that created that whole pull off from the NIH. If you read the literature really carefully and look at that, it is women who had been postmenopausal for more than 3 to 5 years. So it's a long time out. So you want to get on the hormones when you're starting to notice that your periods are falling off. You're in the perimenopausal period, that your GYN can check you. Once you're on the HRT, hormone replacement, if you have a uterus, you're going to need to have something with estrogen and progesterone in it. That's a combo. If you don't have a uterus, you don't need the progesterone. But if you're on the combo and you have a uterus, you need to start the first year. You're going to need vaginal ultrasounds to watch the lining of your endometrium. And you're going to then need vaginal ultrasounds yearly for your life, as long as you're on it. And you're going to need your mammograms every year, no matter what, to make sure. Clearly, as Dr. Tosi said, if you've got a heavy family history of breast cancer, then you're going to have to think about it. That's something. And again, what they'll tell you if you have if you are on HRT, which is hormone replacement therapy, and you are taking, say, the combo one, the estrogen progesterone, because you still have a uterus. If you don't have a uterus, that is, you had a hysterectomy, then you don't need the progesterone. But if you are on it, they will tell you that when you fly, you want to take an aspirin, because there is an increased clotting risk on these. And so you just want to know that. And again, you have to talk to your doctor, because if you're already on things, so some of you might be on turmeric, which decreases your clotting. Okay. Some of you might take an aspirin anyway for your heart in general. So you want to see what else you're on. If you guys are taking, which I hope many of you are, or some of the fish oils, they're going to thin your blood out, as is vitamin E. So make sure you share with the person who is giving you your hormone replacement therapy what else you're taking, because you might only need a baby aspirin. Okay. So that's what I do, and then I watch the DEXA scans. But I all women, I agree with you 100%, Laura. We're on this same page with that. So
I'm going to stick with you guys. How common are dislocations? But also like joint laxity, tendon weakness, those issues with mild type OI. So not necessarily bone breaks, but like the other joint issues. Dr. Raggio, why don't we stick with you?
Okay, so number one is tendon issues are the number one issue in mild OI as you age. That's the thing. You're going to rupture your Achilles or your quadriceps tendon before you break something. That's the nature of the way you're built, the way your collagen works. And so that's common. That is known, and that's something where it's why I say you really want to have your muscles strong and you want to be in balance. People think they're in good shape, but they're out of balance. So I examine lots of people who, oh, look at what I can lift, look at what I can do. And then I get them to do a complex activity and they can't do it because they're too tight in some muscles and too strong in others. So the key is you need to have an exercise program that brings you into balance and doesn't throw you off and works with your proprioception. That so something like Tai Chi is beautiful because it gets your head in, gets you standing on one leg, and you work with balance. So I think that's really important to help on, yes, because we know these are common. You shouldn't have that many dislocations. Okay, if you're dislocating a lot, it might just mean that you've torn something so badly that now the joint has no stability around it. So dislocations are not generally, we say at the beginning, that doesn't make me think. That makes me go down a different path of collagen disorders, not OI.
Dr. Tosi?
I generally totally agree with Dr. Raggio. The one exception is I've just had, after all these years, I've had 2 teenagers with patellar dislocations with almost no trauma. And I must say it's made me much more vigilant on my kids. I think that we missed a tracking disorder early on.
Right.
And so that's my only area of disagreement.
Right. But that, Laura, you would say that's probably due to imbalance of the muscles.
Yes,
So
I
their
think that's absolutely correct.
their quadriceps was not as strong in the medial side and off there. And so there you go. So
Right.
I really, yeah, I know. I think that that's important. But I think if you're getting a lot of dislocations in somebody, you really have to, you got to think.
Have we got the right diagnosis? Absolutely.
Right. What would you guys say is the best way to improve bone strength as an individual ages? Again, with mild OI.
Don't lose it.
Right. So that's exact. So the idea is you build your bone until you're about 30. Some people say 22. So for all the young people that are on this call, young meaning you're still under 30, really get your bone up to its maximum. It's like owning a house. You put so much furniture in and you do that till you're 30. And then when you hit 45, somebody comes and starts taking furniture out of your house because you're getting old age osteoporosis. And if you don't have a lot of furniture, you're going to be empty pretty quickly. So that goes to Dr. Tosi's point about so 1, build it. 2, don't lose it. And that's for muscle strength. We know that bone talks to muscle and muscle talks to bone. That's proven in the laboratory. So the idea, the stronger your bone is, the more it will say to the muscle, keep working. And the stronger the muscle is, the more it says to the bone, keep working. And they work both on a biomechanical way. So they're pulling on each other, and they work on a biochemical way. They're sending signals to be stronger. So that combination, it goes back to that being strong. And you can sit in a wheelchair all day. You could sit in a chair all day. You can lay down all day, and you can still build your muscles and build your bones. So I always say to people, there's no excuse. If you're sitting, you really, really, really have to work on that. So I think that that's one way to do it. And then the other way we talked about is if you're a woman, look at when you get to your perimenopausal period. If you're a man, think about talking about androgen replacements and testosterone replacements. Again, that's an area that you want to look into. And then, keep active, swim builds muscles so that you have the muscles to walk with.
And the only point I would add on that is that bone is very fussy. It doesn't like to come back. It will come back for our young kids. And because I run a bone health clinic that looks at all kinds of different bone diseases, I am constantly amazed if a kid has cancer, whatever, as long as they're under 5 or 6, it's going to come back. Our bone gets old really fast and it loses that capability of repair. And so maintaining it is paramount. And that's why I'm so emphatic about the hormone replacement therapy, because none of the drugs we have on the market right now come close to what estrogen is doing for our bone every day.
Thank you. We're closing in on our time, but real quick, I wanted to ask, what are your thoughts on vitamins and supplements? We talked about vitamin D, as well as a choice between ibuprofen and Tylenol. Is one better or worse? If there was like one supplement or one vitamin, what would you suggest?
I think beyond vitamin D, we don't have good data. There's all kinds of rumor mill stuff out there, but right now for supplements, I would say that's the best we have. Kath?
Yeah, I agree. The key to building your bone is the vitamin D, and you need to know your level so that you're taking the appropriate amount, as well as making sure you get a well-balanced diet. And if you're not getting a well-balanced diet, then you probably want to supplement with a multivitamin that has in the calcium and the magnesium, but hopefully everybody's eating a well-balanced diet. Tylenol versus ibuprofen. So for bone, most of us prefer Tylenol because ibuprofen can slow down the initial healing when you look at the experiments. So most of us stay away from ibuprofen and we'll go with Tylenol. Having said that, you all know that Tylenol is bad for your liver and ibuprofen is bad for your kidneys. So you really have to balance out how long you're going to stay on anything. You don't want to feed the bone and kill the liver or kill the kidneys. So I think that is going to be that's really important to balance out.
Great. A follow-up to the DEXA question very quickly. For OI patients, should they just be getting one hip and their spine scanned, or should they get more body parts scanned? Is that better overall?
So it depends. Normally we would do hips, spine, and sometimes the forearm, but it depends on where you've had instrumentation. So if you've had roddings in your hips or in your spine, you can't do that. You're not going to be able to do that area and do it. So it should be generally we do the spine, we do the hips, and we'll do the forearm.
Great.
One of the interesting new ways of monitoring bone density is with CT scans. And no one's recommending you get a CT scan to measure your bone density, but as long as there isn't hardware in your spine, there's some very exciting data that I think is going to improve over the years with additional insights into the quality of your bone. So my one thought for you is, if you ever get an abdominal CT for any reason, demand a copy of the CD and just keep it.
Great. My final question, I'm going to send this to all the panelists before we head out. And I have put the link for the women's health session in the chat because we will definitely be talking about hormone replacement therapy there. If you had one tip to make a difference in your daily life as living with an adult with mild OI, what would it be? And I'm going to start by putting Carolyn on the spot because you're the first person I see.
Oh my gosh, I don't know if I have one tip really. I guess I would just go with self-advocate. You know your body better than anyone. If a doctor is not listening, find another doctor. Our medical experts, I'm so grateful, Dr. Raggio, Dr. Tosi, they're just so available, really know us and listen to us. So we're very lucky. So definitely utilize all that the OIF website offers, and the office there, they're fantastic. If you have a question or a problem, call them. They'll help you get to the answer. And I guess that's it, self-advocate.
All right, Jeffrey, I see you unmuted yourself.
Yeah, I think it's be kind to yourself. Yeah, I mean, be kind to yourself and listen to yourself. And, you know, as life changes, and just, and listen to your body, and understand that you do need more time between activities, or getting home from, if you are going to an office for work, or even if you're working from home, and then for your evening, you know, do something that helps you reset, whether it's sitting outside, sitting on the couch, taking a shower, just something that kind of really helps you reset to that next phase of your day or whatever.
Thank you. Jacqueline.
I would say, no matter how bad of a day you're having or whatever's happened to you in the moment, you are not alone. And you're not the only person this has ever happened to. And I bet if you reach out, whether it's virtually at the OIF Facebook page, or on their Instagram account, or call them, or to one of your friends, don't be afraid to say, you know, I need help, or I'm having a bad time. I just want to have a sounding board, or I just feel all by myself, because it can be very isolating, especially if you don't know anybody else in real life that has the same problems as you. So you are never, ever alone. There is somebody out there. So please don't stay quiet if you need just a connection.
Thank you so much. And I did put the OIF's email address, bone link at oif.org, in the chat. If you have any questions, feel free to reach out and we can help direct you. Robin, what is one tip that you have?
So one tip that I would have would be curious, find out more. Again, it goes into advocating for yourself. It goes into having an awareness of yourself, and awareness of things that make sense and don't make sense. Be curious and learn and listen, and reach out to people who can help, or who can advise, or who can just commiserate, if nothing else. Thanks, guys.
And Christine, bring us home.
I would just say, listen to your instincts and your gut. Oftentimes I think we go to specialists or, you know, various doctors, and they'll tell us, well, no, this isn't how it should be. But really, we're going to be more of an expert around OI and how those things relate than necessarily other specialists who don't know OI are. And I think, you know, oftentimes when I've listened to my gut, and a doctor's told me something different, and I've kind of said, okay, I'll defer to them. When they weren't an OI specialist, I was usually right. So I think listen to your instincts, your gut instincts. And we have amazing doctors like Dr. Tosi and Dr. Raggio, and thank God for them, because anytime I got bad advice, I would go to them and they would say, yep, it's probably the, you know, what you're thinking. So I think just trust your intuition. If something doesn't feel like it jives, then it probably doesn't, and seek out the OI Foundation and seek out the experts, because they're there for you.
Thank you so much, Christine. And with that, we are going to end
Alyssa?
our Oh, yep.
Nope.
Dr. Tosi?
Yes. So let me just be a pain in the tush and remind you, we really, really need your help to try to define how things are changing, and they are changing all the time. Kathy has her survey. We have a new COVID survey coming out in a couple of weeks. I know you have survey fatigue. Everybody does. But we're not going to know what's really happening unless people help us and participate. One sort of paid political announcement. I know that the OI registry is a little bit of a pain, and it's a little bit of an extra step when we do surveys. But what it does is it means we can ask you more questions. because once you've filled out information about you, then we know your age, your race, your ethnicity. We know a lot about your OI, which means that our data, what we get back to you, is better than, you know, oh, what do you think? You have mild, moderate, or severe. It's not good enough as we are trying to track what's happening in this rapidly changing disorder. So I beg you, let's be blunt. I beg you to give us a hand and be sure that you respond to the requests to answer surveys. We are looking to make it more standardized over time. We hope to have major data collections. If we can just get enough people to help us, we can do it. The government's not going to do it for us. Much as I love being a site for the natural history study, there's just so much fundamental stuff. It isn't going to really address particularly adulthood. And it isn't, I hope we get funded for forever, but we can keep the registry for forever. We may not keep NIH funding. So investing in those tools that will help for the long term. I always say, this is your 401k, folks. Please invest in your 401k and the registry. Kathy, you want to make a bid for your survey too?
No, I think it's great. Again, Laura, thank you so much. And the impact survey is important. And so please go on, especially if you're a male. We need men, right, Laura? We need men desperately.
Yeah. Well, and if you have a chance, you know, we're still recruiting for the natural history study. And the problem with the natural history study is it's 60% kids. And you folks who are adults, this is an adult call. We need more of you involved. Please join us.
All right, thank you everyone. And I'll let you go. We have the dental session that's currently in progress. Women's health is happening at 3:30 Eastern time. Thank you all so much.
Nice to see you all.
Thank you.
Bye.
Bye, you guys.